Yeah, definitely. Next Tuesday's good. Next Tuesday.
All right, you guys. Quit horsing around. We're going to talk about sex. Okay. So we just have these last two chapters to go. Exam, of course, is on Thursday and Friday. You can take it either Thursday or Friday. Thursday, remember, is an hour and 15 minutes. Friday is 50 minutes. So keep in mind whether or not you're stressed under a shorter time frame. Typically, if you want to have a little bit more relaxed pace, the 4 o'clock, which is what you guys are used to, actually works out the best for you. But I'll be here both times, so see you then.
What's the Friday time?
It's noon. No. So we're going to start this chapter out with the anatomy of the female reproductive system, and we're going to start off with the ovaries, because the ovaries are called the primary sex organs. And that's an important thing, because primary sex organs actually are responsible for producing gametes. And we know these gametes, that the typical common term for them are eggs in the female. Also, the primary sex organ produces hormones. And we'll just use capital H for hormones. And in the female, we know that this is estrogens, and we're going to go with an S at the end of it, and progesterone. No S on the end of it. So this is just to let you know that there are many different types of estrogens. You don't have to know the many different types. I just want you to realize there are many different types of estrogens and only one type of progesterone that are produced by the ovaries. Now, we also call the ovaries female gonads, gametes. These cells ultimately are going to be haploid in number. We'll get into a lot of the meiosis and how we actually count chromosomes in these as we go through this material. Paired organs located on either side of the uterus, held in place by ligaments. And that's important for you to realize. This here is showing you a cross-section of the uterine tube. This here is showing you a cross-section of an ovary. And take a look at what is connecting the ovary to the tube. It's actually not connected physically to the tube end. And so we have a mesovarium. And one of the things for you guys to realize, let's see, erase that, that looks terrible, with mesovarium is mes is referring to mesentery. Can you guys follow that? Mes is mesentery. And you also see in that, you see various blood vessels. So mesovarium, and then mesosalpinx. Salpinx is kind of the Latin term for the uterine tube. So the mesosalpinx is part of a larger structure called the broad ligament. And it's called the broad ligament because it is broad, it's big, it's located on the lateral side of the uterus, and will start at the area where the tubes are, and then go all the way down to the base of the uterus and fan out to the pelvic wall, and helps to keep everything in place. But if you'll notice that the ovary is not encased within the broad ligament, it's attached to it, so it's hanging off of that. So it is actually kind of hanging out there all by itself in the pelvic cavity. Let's go ahead and take a look at some of the structures anatomically. Oh no, it wasn't supposed to do this. It didn't do the, honest to goodness, I had the tech person in here with me, and I was able to scroll up and down the screen with the words moving as I scrolled up and down the screen, and obviously that is not working right now. Let's do something that might help it. Nope, that's not it. Okay, we're just going to have to go with the flow, and unfortunately this is going to take a little more time than I was anticipating. Sorry, people. So obviously you'll have to refer to the recording to see more of the details or your notes, yes? All right, sorry. Okay. Let's go to some of the terminology you're already familiar with as you've been working with the cat reproductive anatomy. Tunica albuginea. That's also associated with the male cat as well as the female cat. It is the fibrous CT covering of the gonad. So it's the actual outer coat. So it's of the ovary, and it is the limit of the ovary. On top of the ovary is this next layer of cells called the germinal epithelium. And as our notes here state, covers the tunica albuginea. And so this is derived from peritoneum. And in other words, it's serosa. So this would be the equivalent to visceral peritoneum, covering the organ itself. The early discoverers thought this is actually where eggs came from, and this was not the case. So let me erase that now. This is really a drag. And let's take a look at the cortical and the medullary areas of our ovary. So medullary area, right here in the middle, cortical area, all the way around the edges. In the middle, that's where we find our vascular structures to actually feed the ovary itself. But let's take a look at the cortical area and realize that it's going to contain a bunch of these tiny little spheres at various stages of development called follicles. And inside these follicles is an immature oocyte. That's the term for the egg. Plus a layer of follicle cells, or several layers of granulosa cells. The primordial follicle is the most immature of these follicles and is the one that has a single layer of squamous cells, which are called follicle cells. So whenever you see only a single layer of squamous cells, those are follicle cells, and that's a primordial follicle. As you investigate the ovary further, you will find some other follicles. So the next one that will develop from a primordial follicle is a primary follicle. Here it is. This is now a follicle that is actually going to try to develop into an egg to be ovulated. And the cells around a primary follicle will be cuboidal. And that's because these cells are actually doing something and producing hormone. And we'll get into that in just a moment. But these cuboidal cells, 1 plus, and there'll be plus plus layers, are called the granulosa cells. So follicle cells are simple squamous, and granulosa cells are cuboidal cells, and there'll be multiple layers, single to actually multiple. And the fewer layers, the earlier that follicle is as a primary follicle. The secondary follicle is when now we have so many cellular layers of granulosa cells that they are actually creating little chambers filled with fluid, and those chambers are called antrums. So primary follicles will develop into a secondary follicle. A secondary follicle will develop into a vesicular follicle, which is also called a mature follicle. And the reason we call it a vesicular follicle is because it looks like a blister. A vesicle is basically a blister. And so when you take a look at an ovary, if you were doing a laparoscopic examination, you would actually see the ovary would actually have what appears to be a blister forming close to its surface. This is a mature follicle, and inside that follicle, that oocyte is going to be ovulated, and once it's ovulated, we call it an ovum, once ovulation actually occurs. The important thing about this vesicle or blister is it's going to rupture. And this is the stage right before the rupture occurs. And so when it ruptures, to release the ovum, it has to go through all of the layers. And so it will go through the tunica albuginea and the germinal epithelium. So ruptures to release ovum, and the ovum is released into the peritoneal cavity. And it's important that you realize that because it's not released directly into the tube because it's not connected to the tube. It's all out there, hanging out there all by itself. I would actually scroll the page up, but I don't think I'm too afraid to do that right now. So it's released into the peritoneal cavity if the uterine tube is not properly positioned to actually pick it up once it's released. So if it's released into the peritoneal cavity, what do you know will happen to that ovum if it actually doesn't get into the tube? It will die. And so it is supposed to get into the tube for fertilization. If it doesn't get into the tube, it's released into the peritoneal cavity, and you have little macrophages that will go around and eventually find it and gobble it up, and it will be all gone. And this is a normal portion of many women's ovulatory cycles or ovulation. Once the vesicular follicle ruptures, we have left over a structure called the corpus luteum. That's all those granulosa cells. And the corpus luteum is very different from the granulosa cells that were actually around our primary, secondary, or vesicular follicle. Because the corpus luteum will have a hormone shift. Because it's important for you to realize that those granulosa cells are cuboidal cells because now they're producing something, and they're producing a hormone. And the hormone they produce is estrogen. And so the more layers you have of granulosa cells, what do you think about estrogen levels? The higher the estrogen levels. And so that's what happens in a normal physiological process here. Few granulosa cells, low estrogen levels, more and more granulosa cells, higher and higher estrogen levels. And once the estrogen levels reach a peak, that's going to be the impetus for that ovulation. And we'll discuss more about that mechanism in just a little bit. But that's the impetus for ovulation. Then when the egg leaves this big bastion of granulosa cells, it's no longer talking to those cells. It's really interesting. When the egg's not there to talk to those cells will change their hormonal production from estrogen purely to now working on towards becoming progesterone dominant in their hormone production. PDOM. Now that doesn't mean we won't get estrogen, but now we are shifting to actually producing a hormone we didn't produce, which is progesterone. And this is important because as we go through this information, we will learn that this is what maintains the uterine lining and prepares the uterine lining for implantation of the egg. So this corpus luteum and its progesterone are vital for proper implantation and furthering the gestation of the implanted egg so that you actually will have a viable fetus and childbirth. The corpus luteum has a finite lifespan if fertilization and implantation does not occur. So finite lifespan means limited. The corpus luteum will only live for 2 weeks max after ovulation occurs. And if no fertilization and then successful implantation, the corpus luteum will become the corpus albicans. And that is basically scar tissue. And this will mean that progesterone levels will plummet to basically their low levels as well as estrogen. So that corpus luteum is a hormonal factor. It's producing progesterone as well as estrogen, and we'll see that. Let me erase again. Okay, so take a look at the pictures because that's where we're going to go next. We're going to go to the pictures down below. And we're going to take a look at the ovary and the cortical area where all these follicles are located. Primordial follicles look like fried eggs to me, don't they? The thing that's in the middle is the oocyte. That's the nucleus of the oocyte. And then you see the simple squamous epithelium around those. Those are called follicle cells. Take a look at the next picture. And I'm not going to draw on this right now because obviously I have to erase every time I want to scroll down. So you guys will have to follow me visually with the directions. Now take a look at that primary follicle. There are multiple layers here of cuboidal cells, correct? The more cuboidal cell layers you have, the more estrogen, because these cells are granulosa cells and they are responsible for producing estrogen. Again, in the center, the thing I don't like about that picture there, C, primary follicle, is that it makes the egg, the oocyte in the middle, look like suddenly it grew really big. But this is actually just a higher magnification. So that oocyte should not be any bigger than the secondary follicle next to it. It's just trying to show you a magnified view. It does not grow. I am not interested in the thecal cells, so don't worry about the thecal cells. I want you to focus on the oocyte and the granulosa cells. Take a look at the secondary follicle picture now, number D there, or letter D. And now you see spaces. Those are fluid-filled areas called antrums. It's important that you remember those are antrums. It's fluid-filled, and you still have lots of granulosa cells, which means our estrogen levels are higher. This is indeed exceedingly important because now let's go down the page and take a look at the mature follicle or the vesicular follicle, which looks like a blister on the surface of the ovary. And see, indeed, we've got a lot of fluid accumulation, and it's distending our germinal epithelium and our tunica albuginea. And when we ovulate, we have to go through all those layers, and those layers then, because we've been distending them as a vesicle, then when the vesicle ruptures, those layers collapse. We have overlapping, and you guys know about epithelium. As long as you have a nice basal layer, it will actually heal itself well, and you'll never actually ever notice that there's any scar tissue on the surface of the ovary itself. Take a look at the corpus luteum there, letter F. It's just showing you this yellowish material, and that's why it's called corpus luteum. It has a yellowish appearance to the naked eye. But I want you to realize that's a cellular structure that's made up of those granulosa cells that have now changed their hormonal priority. They're progesterone dominant, but we still will produce estrogen. But we want to do progesterone because that's the important hormone to maintain the uterine lining for viable pregnancies. Whenever somebody miscarries, it's typically a progesterone problem or a genetic problem. So that's an important thing to realize. Corpus albicans is just showing you that that's what the corpus luteum becomes if successful fertilization and implantation does not occur. It will become scar tissue, and that scar tissue will get reabsorbed. And so you see in the cartoon in the middle of the showing the ovary, you see the primordial follicles there to the upper left. Then our primary follicles, it's showing you that indeed it could be a single layer of cuboidal cells that are granulosa cells or multiple layers. Secondary follicle, fluid actually forms. Mature follicle, big blister-like structure. Then you see ovulation. Now, it's important, too, to take a look at the mature follicle and the ovulated follicle and notice that some of those granulosa cells go with it. Those granulosa cells that are immediately around the ovum are called corona radiata. The queen is wearing her crown around her. Corona radiata. Those are still granulosa cells, and they are there to actually protect the egg. So this ovum that's now been ovulated needs protection and also barriers to actual sperm penetration fertilization, which we'll cover in more detail in that chapter. Let's scroll on down the page. and look at the duct system. The duct system for the human is very different than that for the cat because the cat had uterine horns. We do not have uterine horns. Because the cat has uterine horns, you can have multiple pregnancies that will implant in those uterine horns just like peas in a pod. So you have 2 pea pods, and you can just put as many babies in them as you want. And that's why cats and dogs have their litters. We don't have that. Remember, right by the ovary, there's a skinny little structure called the uterine tube. That's what we have. We have the skinny little structure attached to the uterus, and it's only designed to actually be a transport tube. It's not meant for anything else but to transport the egg to the uterine body, whether or not it's fertilized. So if the egg gets into the tube system, it's meant to go towards the uterine body itself. You know, uterine tubes have multiple names before you actually got into this. You know, in high school or junior high, wherever they taught you sex ed, they typically called these fallopian tubes. Other classes, they may have called them oviducts. And so you have to realize that this part of the duct system, there is a part that penetrates the wall of the uterus as far as our uterine tubes go. So penetrating the wall of the uterus, there's a very small uterine part. Then as we go away from the uterus, that's called distal. The uterus itself is a proximal structure, midline. So now we're going to go off to the side. That's distally. The next part is called the isthmus, and it is indeed a narrow part, and it is about 1/3 the length of the tube. But it is indeed narrow. Then we get to the next section, the ampulla. An ampulla is a widened area, and indeed this wide area curves over the ovary and is the typical site of fertilization. The very end is called the infundibulum. It is a funnel-shaped region. The edge of the tube of the infundibulum has finger-like projections called fimbria. And the fimbria are actually designed to help scoop up the ovulated ovum. So think of these guys here, that little end of the tube, think of them like a very sophisticated chemical vacuum cleaner. And so as the egg develops, remember, estrogen levels are going to be very high, or as the follicle develops is a better term. Estrogen levels are going to become very high, and that's going to promote the fimbria to move over in that area and create a wave-like motion in that area, so that when ovulation does occur, the fimbria are kind of trying to create a pseudo-suction to actually promote the ovum going into that infundibulum area. And once it gets into the infundibulum, it's going to move towards the uterine body. And the reason it's going to move towards the uterine body is there's going to be some things to help it move that direction. You guys have any ideas what might be useful to move it towards the uterine body to have? Microvilli? Cilia, that's right. So we'll have cilia as part of the mucosal lining of the tubes, and you'll also have something to help squeeze it that way. So you'll have a little muscular layer as part of the tubes that will help form peristalsis, which is all designed to actually help move that ovum towards the uterine body. So again, acting like a little vacuum cleaner myself here, trying to move things around. Take a look at this picture here. Again, we see the ovary and it's attached to the broad ligament. You see the broad ligament, that fan shape on one side that's still present. Also, the uterine tube is actually superiorly located, and our infundibulum with the fimbria are over in the area that on the other side shows actual ovulation occurring into that region itself. So that's a nice view of that. The wall of the duct system is going to contain smooth muscle for peristalsis, and the mucosa is going to be simple columnar epithelium with cilia. The epithelium of the mucosa will be. All of this is designed to move ovum to uterus. So actually, when you realize this is actually a bit of a blockade for sperm to actually fertilize the egg, which typically occurs in the ampulla area for us. Now, what if, for some darn reason, fertilization does occur in the tube, but it doesn't make it all the way to the uterine body? What is that process called? Ectopic pregnancies. Are those good or bad? Those are bad. And the reason they're bad is take a look right now at the uterine body itself and take a look at the structure of the tube. The tube's nice and narrow. It doesn't have a really thick mucosal layer. And look at all of this muscle associated with the uterus itself. And compare that to the tube as you take a look at this. The important thing that you have to realize about a fertilized egg is it's actually going to act like a parasite. And the parasite is going to, if it doesn't make it to the uterine body, wherever it stops in its path, it will land, literally, it will land on its feet, so to speak. And we'll see this when we go into the next chapter. And it will start to secrete digestive enzymes on the surface that it lands, because it literally must burrow into the mucosa that it lands on. So it's secreting digestive enzymes burrowing into the mucosa that it lands on. And we have nice thick layers here. And these get even thicker when it's time for implantation to occur because of progesterone. But this doesn't thicken. And so you're burrowing in, secreting digestive enzymes, and you come across a blood vessel, such as an artery. What do you think those digestive enzymes are going to do to that artery? They are going to act like a knife. They're going to open it up, and the woman's going to bleed out. And so that's why ectopic pregnancies are so bad, because the fertilized egg, in order to survive, must implant and must get into a good nutrient supply. And so its digestive enzymes are designed to actually put it into a nutrient pool. And the tube is not designed for that type of invasion. And so an ectopic pregnancy will actually cause potential death of the woman if not caught early enough, as well as obvious demise of the fertilized egg. Pregnancy is not a safe condition.
Will that tube be destroyed after that too, or will it never be able to go back?
The tube is typically removed. So surgically, if you have an ectopic pregnancy and they go and they will actually remove that tube. So therefore ovulation, in order to get pregnant, you actually have to have ovulation occur from the other side in a healthy tube. There's all kinds of things that actually can make tubes unhealthy, and that's one of the things is pelvic inflammatory disease. There's various infections women can get with chlamydia that is a silent infection and cause scarring of their tubes. So. Keep referencing to the picture above as we talk about the uterus itself. It is anterior to the rectum anatomically, posterior to the urinary bladder, and slightly superior to that. It has various regions that we're going to take a look at, but remember, it is anchored to the body wall by broad ligaments on either side. The body of the uterus is the main part, has a very nice thick muscular layer, nice endometrial layer, and then a serosal surface. The fundus, you guys remember the fundus of the stomach? The rounded upward projection. So whenever you hear the word fundus, you should automatically think rounded upward projection. And indeed, that's what the fundus is of the uterus. Now the cervix is the narrowed part or the outlet, often called the neck. It has an internal plus external openings called osses, and in between them is the cervical canal. So the internal os is close to the endometrial lining or the mucosal lining of the uterus, and the external os is right there actually protruding into the vaginal area. So which area is utilized to do pap smears from? The external os. And that's because as you take a look at your picture up above, these notes here, below us, below the uterus is the vagina, right? What type of epithelium lines the vagina? What makes the most sense? It's a stratified epithelium. Cuboidal, columnar, squamous. Squamous. Because, remember why we have stratified squamous epithelium. What's the main reason? Protection, to protect us against abrasion and friction and things along that line that's going to occur. And so it is, the vaginal area is stratified squamous epithelium, because when a baby comes down that birth canal, you better believe there's some abrasion, and also during intercourse. There's some friction and rubbing, and so that's an abrasive type of action. So indeed, it's stratified squamous epithelium. Well, take a look at that. Think about the vaginal lining, and take a look at how it's probably going to go over the protruding part of the cervix into the vagina. It's going to be part of the external os. But now take a look at the internal os, and what is the cell lining of the internal os more like? It's like the uterine mucosa. And so we have a transitional zone there. We go from stratified squamous epithelium to actually a columnar epithelium as part of the uterine mucosa. And in that cervical canal, there is a transition zone. The cervical canal also is going to release secretions, very thick mucus secretions. If we have thick mucus secretions, do we get that from squamous cells or cuboidal or columnar cells? Columnar cells. And so that cervical canal between the external and internal os has a lot of glands that are responsible for secreting cervical mucus, and that's there to actually create a barrier to the outside world. Do you guys realize that we are just looking at the actual only barrier to the outside world right now? That cervical canal and the mucus in the cervix? The ovary is not attached to the uterine tube. The uterine tube is open at its end over the ovary. In other words, let's go on down there, take some sort of foreign object from the ovary, which is kind of, an egg is sort of foreign. It's half you, it's not really you. And it's going to go down that, and it's going to go into the uterine body. And if fertilization doesn't occur and we lose the egg, the oocyte with menstruation, it's going to go through the cervical canal, correct? Into the vagina and then out to the outer world. Well, where's there a blockage? Where is there a true, actual physical barrier in any of this? You guys see, there is no true physical barrier. The only physical barrier is the cervical mucus. Is the only physical barrier to the outside world. And it's very effective because you don't get peritonitis. Do you guys realize that you had a ascending bacterial infection that went through the cervical mucus and into uterine lining and into the fallopian tubes or uterine tubes, then it could go into your cavity and give you peritonitis. So there's so many protective barriers to protect women from the outside world, which they have an absolute connection or opening to. So this cervical canal is a very important barrier to the outside world and very protective. So cervix with its external os and internal os, and the canal in between with a lot of glandular cells helping to make the cervical mucus or mucus plug. All righty, another erasure. It makes it easier to erase a little bit at a time instead of a whole bunch. Wall of the uterus. Let's take a look at the various layers. Perimetrium is a kind of a bit of a misnomer. Also, what that means, it's not a very good name for it. It is literally visceral peritoneum. So you know that's just a serosal surface. So the uterus is intraperitoneal, correct? All right. Myometrium, well, that's just basically the muscular layer, and you know what kind of muscle it is, right? Smooth muscle, and very thick, and will be able to actually distend or be stretched and actually make many more as the uterus grows whenever there is a viable conceptus inside. I will also use the term conceptus because conceptus means conception has occurred, fertilization has occurred, and you have no idea whether it's the zygote two-cell stage to a 40-week term fetus in there. So conceptus carries a broad time frame. Endometrium is the lining inside the uterus, and so that's a mucosal lining. Remember, mucosa is epithelium in the CT that keeps it attached to the myometrium, and the endometrium has two basic strata or layers. Remember the skin, stratum basale and all that kind of stuff? So here we actually have stratum functionalis and stratum basalis. Which of these two layers is closest to the myometrium? That's right, stratum basalis. Good, good. You guys are remembering how to keep things organized. Excellent. So stratum basalis is the basal layer that will replace or give rise to, however you want to, because remember, stratum basalis gives rise to replacement cells. So stratum functionalis is that layer that is actually sloughed or shed during each menstruation. So functional layer and I'm going to say menses because it's shorter than menstruation. Next time I start this program up, if they don't have it fixed, I'm going to have the IT guy standing right here to where I don't have to do this, where it will actually scroll. Because when he was standing here, you know how it is. When it only doesn't work when your help is not there. When they're standing right there, everything works wonderfully. Going into the vaginal area, it's also referred to as birth canal, and it has three tunics. Remember, tunics are basically layers. We have the adventitia, and that is fibroelastic, and the adventitia tells you whether it's intraperitoneal or retroperitoneal, correct? When you hear the term adventitia, you should think retroperitoneal. So the vagina itself is a retroperitoneal structure. It has a muscularis layer, and there's two layers of smooth muscle. And then a mucosa that is actually, as we just talked about earlier, it's a stratified squamous epithelium that is organized into rugae. Remember what rugae are for? For distension, right? And so when there's nothing going through it, we have a lot of rugae. When there's a baby's head going through it, we don't have much rugae left anymore. So it's designed to help make that area distensible itself. The interesting thing is that the mucosa does produce acidic secretions. And the pH can typically be anywhere from 3.5 to 4.0. And why is that beneficial? Inhibits bacterial growth, that's right. Absolutely. The external genitalia is referred to as the vulva in kind of a generic term. And we have our mons pubis, our labium majora, our labium minora, and the clitoris, all part of the external genitalia. The mons pubis is basically fatty tissue that is over the symphysis pubis, serves as essentially a pad. The labium majora, two skin folds running from an anterior to posterior aspect from the mons pubis, so from the mons pubis anteriorly, and is analogous to the male scrotum. The labia minora are two mucosal folds, so those are hairless, that enclose an area called the vestibule. Inside the vestibular region, you will find from anterior to posterior aspect, you will find the clitoris. You will find the urethral opening. My speller is. You will also find the passageway to the vagina itself, and posteriorly you will find some glands. The clitoris itself is indeed erectile tissue that is analogous to the glans penis of the male. Mammary glands, functional only in the female. What's interesting, they're actually modified sweat glands, so they belong to the integumentary system. The structures that I want you to be able to identify with the mammary glands is an area called the areola. That is the pigmented skin that surrounds each nipple. The breast tissue itself is actually subdivided into lobes. And we have about 15 to 25 lobes internally. The separation that creates the lobes is connective tissue. And then the breasts are attached to the anterior chest wall with some connective tissue segments called suspensory ligaments. So CT attachments. What's the muscle that they're going to be attached to? Pectoralis major. So the pectoralis major muscle has a normal CT coat, and then the breast tissue actually has some CT extensions that actually literally attach to the pectoralis major CT. There are suspensory ligaments. They even have a person's name attached to that name, but we won't go there. You guys have enough names to learn as it is. Now we're getting into the complicated story. It's all hormones and glandular activity. Physiology of the female reproductive system. The story of oogenesis, that which is going to produce oocytes. So oo and genesis. Oogenesis is a process that starts before birth. So here we have embryonic and fetal period. The oogonia are diploid, and they're basically referred to as germinal epithelium or the stem cells for oocytes. So oogonia have the potential to do lots of things, but their primary job, because they're located in the ovaries, is to produce oocytes. They will produce a whole bunch of oogonia until they have populated the ovary. So oogonium in order to populate the ovary with themselves, what would be the usual process you would expect to actually occur for these oogonium to actually produce more of themselves? Mitosis. And so that's important. They will undergo mitosis until there's enough oogonium for a proper ovarian population. So these are the precursors. These are the mother cells, so to speak. And if you're undergoing mitosis, how many sets of chromosomes do you have? 2. So we have 2 sets of chromosomes and 23 per set. And so that's why you see here 46. So we will make enough oogonium until we get to the proper population, which is actually several million per ovary. And then once we get to the proper population of oogonium per ovary, we will then create a process called meiosis. So up above in the blue, the oogonium will populate until we get enough, and that's a mitotic process. And then once we're done with the mitotic process of creating oogonium, creating this population, I want you to realize the population is established first. Then, and that's a mitotic process to establish a population, then the cells go into a process called meiosis. So once we complete our population, we'll start meiosis. Meiosis and mitosis sound very similar, and I want you to realize they are very similar. Do you guys remember the phases of mitosis? Prophase, metaphase, anaphase, telophase. Okay, so those phases of mitosis are also replicated in meiosis, but done twice. So we have prophase, metaphase, anaphase, and telophase. Whenever a cell, a gamete, undergoes meiosis, we do that twice. And so that's why we see here meiosis 1 is arrested. So we go into meiosis 1, and we go into actually just prophase. So it's prophase 1. and then stop. So in other words, we enter meiosis 1, and then we go into a state of suspended animation. And this is while we're in utero. So this is in the egg, in the ovary. That's actually occurring before childbirth actually occurs, before you're actually born. So again, please note, before birth. So we are in meiosis 1, it says primary oocyte arrested in prophase 1, right there, and it's in blue. We are now in childhood, and we are still in meiosis 1. So we're not making any more potential eggs or anything. We're still stuck in meiosis 1. Well, I want you to think about this. If we have all of these potential children, isn't that what our ovaries are full of, potential children? We have all of these precursors to children in our ovaries, and we put them into a state of suspended animation not long after we get the proper population. And then we're born, and then we go through childhood, and then before we get into puberty, how many of those potential children or eggs do you think survive this long time frame? Do you think all of them do? No, they don't. And so this is an interesting process because we go, all of those oogonium become primary oocytes as soon as they enter meiosis 1. So if you see primary oocyte, you have to realize it started meiosis 1 and is stuck there. And it's stuck there until it receives the proper signal to actually complete the process. And when do you suppose the proper signals to complete the process of meiosis to produce an actual egg is going to start for a woman? In puberty. And puberty involves a hormonal process, correct? A hormonal manipulation. And that's going to be by our anterior pituitary. And the anterior pituitary, remember, produces various hormones. And those are FSH and LH. And once those hormones are being produced in a cyclical fashion, puberty starts, and our hypothalamus will actually control that by gonadotropin-releasing hormone. You guys remember way back at the beginning of the semester when we did endocrinology? Well, endocrinology is coming back to haunt you again. So that process is what actually starts puberty. So it's a time process. So here we are monthly now from puberty to menopause. We're still, if you notice, we're still in meiosis 1, arrested, because take a look, 46, 46. So with this process of meiosis 1, we've actually had some chromosomal replication that actually occurs, because that's part of the process. So chromosomal replication has occurred, but you know, when you have one chromosome, you guys remember with mitosis, you have one chromosome and it replicates, creates another one, and they're still attached at the centromere. You guys remember that story? So we have had that. That's what meiosis 1 has actually done. We have had a chromosome that has replicated, but it hasn't separated. So we have this intact double chromosome. You guys follow me with that a little bit? It's a little confusing. So these chromosomes are there hanging out. It says 46, but I want you to realize that this replication has actually occurred, but they're still attached. And as long as they're still attached, we call that intact thing a chromosome. You guys follow that part? So that intact thing is a chromosome, and with proper stimulation of FSH and LH, this primary oocyte will become a secondary, primary oocyte, which is inside a primary follicle, will ultimately become a secondary oocyte once we actually separate the chromosomes into separate cellular structures. So down here, take a look, we have 23 and 23. So meiosis 1 occurs during embryology and gets stuck in prophase 1, and then in puberty, it gets turned back on to complete. And so we have these 46 chromosomes, and when we complete meiosis 1, we'll have those chromosomes go off to 2 different cells, One is going to be a secondary oocyte. So when you hear the word secondary oocyte, that means meiosis 1 has completed. And now we are going to go into meiosis 2. The other cell that we actually have with that is that polar body. I'll erase this so you can see it a little bit better up here. The polar body. And if you'll notice, it has 23 in it. Whenever you see a cell that has 23 chromosomes, that's called a haploid cell. When you see a cell that has 46 chromosomes, it's called a diploid cell. Diploid, 2 sets of chromosomes. Haploid, I don't know why, but 1 set of chromosomes. So that shows you that there was separation of our chromosomes into these cells, which are now secondary oocytes. There is a big difference between that polar body and the secondary oocyte that's actually going to go on and actually mature further. What is the big difference to you? What do you see between the polar body and that secondary oocyte? One is really big and the other one is really small. What I want you to realize, that's the way it really is. That polar body is just a collection of chromosomes. The secondary oocyte is actually a whole bunch of cytoplasm and chromosomes. Which one will survive? The one with cytoplasm. Correct. That's what's important for you to realize. This process is done to actually try to promote only one oocyte actual formation for fertilization. Not 2, not 3 or 4, 1. So the first polar body does not get cytoplasm, does not get cellular machinery, does not get endoplasmic reticulum, does not get mitochondria. It just gets shafted. That's what it gets. It gets a whole bunch of chromosomes and nothing else to sustain them. And the secondary oocyte that is actually here gets a whole bunch of cytoplasm and a package of chromosomes. Now the secondary oocyte has completed meiosis 1, and now we're haploid, and now we're going to enter meiosis 2. Secondary oocyte goes right on into meiosis 2. But guess what happens? Meiosis 2 gets arrested, gets in suspended animation. It doesn't complete either. So I always tease men and women about this. See, women are always hesitating. They're always reserving the right to change their mind. Then when you say, come on, honey, let's hurry up, they go, just a minute, I'll be there. So this is all the way to the genetic scale here during meiosis. Meiosis 1 gets a pause, a long pause. Meiosis 2, we also get a pause, but the pause is nowhere near as long and is hesitating, not completing the process. Because with meiosis 2, this guy here is going to separate again and give us still haploid cells. So here is a haploid cell giving us 2 haploid cells. Again, another polar body and the ovum. The polar body, again, is not viable, correct? And it's meant to be this way because we want all of the stuff that you need to go on a camping trip with the one that's going on the camping trip. And also I tease men and women about this because when you say, yes, dear, let's go on a camping trip, I'm saying the guys are saying it to their gals, they say, you don't need to bring all that stuff. And they go, yes, I do. And even from this meiosis 2 process, they know they need to pack a lot of stuff because the guys are going to forget to bring a whole bunch of stuff. So indeed, this ovum here is packed full of material that will allow it to survive for weeks inside the uterus before our implantation actually occurs, because successful implantation takes about 2 weeks. So this ovum has to make sure it has all of the nutrient and mitochondrial and all of the enzymes needed to live for 2 weeks without another food source. So this is why this process actually occurs. We have to have a nutrient-rich survivor. And that's what that ovum, which is no longer a secondary oocyte because it has completed meiosis 2 to actually be. And I want you to I'm going to erase again up here. And I want you to notice in the notes, meiosis II is only completed if fertilization occurs. So what that means is when you ovulate an ovum or an oocyte, it is in meiosis II. If fertilization doesn't occur, it can go into the uterine body, it can hang around out there, but it will not implant and it will be lost with menses. So, and it's not viable because it hasn't finished all of its meiosis. And it's not viable because how many kids do you know actually go around living with just 23 chromosomes? Nobody. So it only has 23 chromosomes, and it's a non-viable entity if you want to give it that distinction. So it's a non-viable form. Because in order to survive, you need 2 sets of chromosomes or 46. What about 3 sets of chromosomes? Will you survive if you have 3 sets of chromosomes? No, that's also non-viable. The only way you can be born is if you have 2 complete sets of chromosomes. You can have a couple of extra chromosomes, but not a whole set. So you cannot be triploidy. You know, plants can be triploidy. Plants are unique in that aspect. Humans, however, we can only exist in the diploid way. Okay, let's go ahead and, again, erase a bunch of stuff. Take a look at this. Understanding this chart is very important to understanding the material for this chapter. We'll go along the other side a little bit later. Let's take a look at the notes about oogonia. Oogonia are like, we're going to take a look and find that we have another cell line very similar in the male called spermatogonia. There are the primordial germ cells, and these are mitotically active cells. They recreate themselves, and we go from 46 chromosomes to 46 chromosomes. In order for oogenesis to occur, during development, remember, embryologically, all of our primary oocytes, oh, actually, not embryologically, because those are primordial oocytes. If we have primary oocytes, that means hormonal action is starting to occur. Primary oocytes are ones that enter into meiosis I. But remember, they do not complete it. They start it and do not complete it. And this begins every month after puberty. What's important is several primary oocytes are recruited to develop but only one will make it. And I'll put in parentheses, usually. And why do I say only one will make it usually?
Twins.
Twins. And are they going to be identical twins or fraternal twins? This is fraternal twins, because fraternal twins means we actually have a totally different egg that is actually the twins come from. So several oocytes will be stimulated to actually develop and create the primary follicles and secondary follicles. But what's going to be important, this is a bit of a race or a game. There's typically only one winner. So we'll recruit a whole bunch to actually run the race, but there's always the one winner that's supposed to finish the race. And so what that means is, of the oocytes that we recruit to start this race, we lose a whole bunch for that one winner that actually makes it through and is able to be ovulated for us. When meiosis I completes, we now have a secondary oocyte. The secondary oocyte is haploid. One set of chromosomes, just 23 chromosomes. And because meiosis I is completed, we also have one polar body. Let me ask you, what if for just some reason, not this polar body because it would be the second polar body that forms, what if we actually had fertilization of the second polar body that actually forms? What does that mean? Fertilization means that they came together and we have 2 sets of chromosomes, so we have 46 chromosomes. What are you going to do? You're still going to die, right? Because where's the rest of the machinery to survive 2 weeks? So you can theoretically actually have fertilization of a polar body, but it won't matter because sperm is actually a packet of DNA and a polar body is just a packet of DNA. You put 2 packets of DNA together, theoretically you have a zygote, but you don't have anything that will allow it to actually survive. And so polar bodies are, you have to realize they are meant to be discarded. They are designed to be discarded. Secondary oocyte means that we have completed meiosis 1, and so we will go into meiosis 2, but meiosis 2 will only complete if fertilized. And fertilization is the joining of 1 sperm and 1 egg for that. Whenever we have the egg ovulated, I prefer to call it the ovum for ovulation. You'll find a lot of people will have different definitions for ovum or ovulate, or that which is ovulated. Oops. This is okay. Now, let's take a look at the ovarian cycle and realize that we have a lot of things occurring because of hormone levels and they're impacting different organs. So we have hormone levels impacting ovaries. We have hormone levels also impacting the uterine lining. And we have hormone levels impacting the egg development. Not just the follicle development of the ovary, but the development of the egg or oocyte itself. The top picture that we actually have here shows ovarian cycle, and it shows us primary follicle that grows into a secondary follicle, which will grow into a mature or vesicular follicle, and then ovulation occurs. After ovulation, we will get that corpus luteum, which will start to regress if we do not get the proper signal back for successful implantation and ultimately the development of corpus albicans. The ovarian cycle is going to take 28 days. Does it take 28 days in all women? No. So most women know, and actually most guys know by this stage in their lives, that not all women are created the same as far as how often they menstruate. Some women will menstruate every 3 weeks. Some women will menstruate every 28 days. Some women every 35 days, some every 2 months, some every 3 months. Who wants to be the lady that menstruates every 3 months? Oh, yeah. Because menstruation is a real pain for socialization. So the women that don't menstruate very frequently are going to have a big difference in their cycle. So this is a cycle that's based upon the ideal woman who menstruates every 28 days, and there's no woman that thinks it's ideal to menstruate every 28 days. But that's what this is all based upon. Now, this is based upon some important hormones that are going to initiate this process. So let's take a look. I'm going to move on down the page a little bit, and let's take a look at gonadotropin levels. Gonadotropins are FSH and LH. FSH stands for follicle stimulating hormone. LH stands for luteinizing hormone. So once puberty starts, gonadotropin releasing hormone is going to stimulate the release of these 2 guys. So take a look here. There's FSH and there's LH. Take a look up here, and then take a look also down here. So we have we've gone from a primordial follicle into this primary follicle. And that primary follicle has a layer of granulosa cells there that are producing the hormone estrogen. Take a look down here. Here's estrogen. This is the beginning of the cycle, and the beginning of the cycle is typically identified as the first day of menses or menstruation because it's something that's identifiable. And that's why we call that the beginning of the cycle. Our estrogen levels are low, very low, and our progesterone levels are very low. When estrogen and progesterone levels are low and you have made it into adolescence, then gonadotropin-releasing hormone will rise and cause the release of FSH and LH. Take a look at FSH levels. It's kind of plateauing here. It starts to go down as the estrogen levels rise. So FSH is stimulated to be released by gonadotropin-releasing hormone. And as our follicles get bigger in size with more granulosa cells, which are producing estrogen, our estrogen levels rise. As the estrogen levels rise, look what it does to FSH levels. Yes, increasing estrogen levels stop FSH release. So it's a negative feedback. High estrogen levels will cause low FSH levels. Low estrogen levels will cause high FSH levels. You guys got that part? Okay. So estrogen levels will then suddenly, because look at all the cells that are actually developing here, will hit a peak. What's interesting is estrogen causes negative feedback on FSH and FSH release predominantly. But then when it hits like this really high level, it actually has a opposite effect. Instead of a negative feedback, we have a positive feedback, and it will cause an FSH, but more importantly, look at this LH level, an LH surge. So this area is called LH surge. This LH surge is directly related to high estrogen levels. When we get that high estrogen levels and the LH surge, that will bring about ovulation, which is typically mid-cycle on day 14 of a perfectly 28-day cycling individual. And then the estrogen levels will drop because ovulation occurred. You guys remember? As long as the oocyte is developing in its follicle and getting more and more granulosa cells, we'll get higher and higher estrogen levels. Once we lose the oocyte with ovulation, those granulosa cells no longer have a boss to tell them that you're estrogen dominant. They switch their gears and they go from estrogen dominance to progesterone dominance. And take a look at what's now happening after the LH surge and ovulation. Take a look at those progesterone levels. Progesterone levels indeed rise, and over a 2-week period will hit a peak and then will start to decline. So take a look at those progesterone levels hitting their peak and then naturally declining if something doesn't help them to stay elevated. We still have estrogen being produced by our corpus luteum, but the predominant hormone that's the super important one here is progesterone, because progesterone is going to be important in creating a fertile uterine lining for implantation. Oh, I'm sorry, guys. It's time to stop. I just realized I had gone past my time frame. I wasn't trying to startle you, but I just looked up and I was so into my story that